Hello, good evening, everyone.
Hello, Bindu.
Hi, ma'am. Hello, sir. Hello, Dr. Rajvi.
Hi.
I think the host should keep everyone muted.
Yeah, there's a lot of
Except for the speaker, yeah. Lot of
All are
background.
muted.
Yeah,
You can start.
yeah.
Yeah. Can you all see my slides?
Yes, we can see.
Okay. Can we start, ma'am, now?
Yes.
Yes.
Sure, we'll start.
Yes. Good evening, all. So today, on 8th of August 2024, the lucky 8 number. Yeah, 888. We have a great CME today by a special interest group, Environment and Infertility, and SIG of Holistic Medicine in association with IFS Vidarbha Chapter. We are having a webinar on impact of environmental factors on infertility. We all know that research consistently has shown that lifestyle and environment factors like what you eat, how well you sleep, and other behaviors have profound impact on health and other diseases. And fertility is not an exception. A number of environmental and fertility factors have shown significant effect on fertility in including men and women, where factors like nutrition, their weight, exercise, different occupational exposures to substances, and even substance or drug abuse and certain medications do affect fertility in both men and women. So we all know how important it has become in current generation. So what here today with this introduction, I would like, I'm not able to move the slide.
Click on the slide.
Yeah, I'm clicking. It's
Not moving.
Yeah.
Yeah.
So with this, we would like to go ahead and start our CME today. And for this, I would like to welcome our esteemed speakers and guests today. So first of all, I would like to invite Dr. Sushma Deshmukh ma'am, Dr. Rajvi Mehta ma'am, convener of the SIG groups, Dr. Bindu Chimote ma'am, secretary IFS chapter, Dr. Jatin Shah sir, Dr. All are there. So everyone all, I would like to invite you all for Samay Lightning. Kalyanam, Arogyam, Dhanasampradam, Shubham Kurutam Kalyanam, Arogyam, Dhanasampradam, Shatrubhuddhi Vinashaya, Ekajyotir Namosute, Ekajyotir Namosute, Shubham Kurutam Kalyanam, Arogyam, Dhanasampradam, Shubham Kurutam Kalyanam, Arogyam, Dhanasampradam. So with this, again, I would like to invite you all, welcome all. And now I would like to hand over the mic to Dr. Sushma Deshmukh ma'am for her welcome address.
Thank you, Payal. A very good evening to all. At the outset, today it gives me friendly wala feeling to welcome you all on this Friendship Day week on behalf of Indian Fertility Society as a national coordinator of SIG, Environment and Infertility, in association with the SIG Holistic Medicine led by Dr. Rajvi and IFS Vidarbha Chapter led by Dr. Bindu Chimote. So, dear friends, friendship is like an umbrella. The same feeling I always having with IFS. IFS is also like an umbrella. It covers 29 chapters, 20 SIG groups, and proud to be blessed by IFS. And thanks to our president, Dr. Pankaj Talwar and Dr. Shweta Mittal for being with us. So, I always think that the environmental factors and holistic medicine always go hand in hand. And as you know, friend is a friend, God's another hand that God has extended. So we all global friends working on infertility are worried that we all are witnessing there's a dramatic slump in infertility and the world is changing, becoming Mr. and Mrs. Perfect technically. In this busy mad world, people are heavily overloaded. Everyone has become workaholic with so many addictions and alcoholic. Sperm parameters are deteriorating. So we approached our brilliant embryologist, Dr. Rajvi Mehta, to throw some light on decline of sperm counts. But we thought, what about oocytes? Oocytes are so exhausting, prematurely aging, late marriages, late planning, modern gases, alcohol, smoking, junk food, adulteration, mobile internet addiction, along with friendship and also the friendship with plastic and aluminum foils. No exercise, but only stress mentally and physically. Or is asking, help, help, what to do? So we communicated, friend of friends with strong academics, who is, gamete friendly. And gametes listen to his command with wonderful pregnancy results. And he is none other than Dr. Jatin Shah. He is going to disclose the secrets of his results. So only one word is for that, is a friendship. So environmental factors affecting ovarian reserve and tips, is going to give the tips for this management. So welcome Dr. Jatin Shah, Dr. Azvi. Now two handsome friends. They are always yes, dosti ki khatir. And very good clinicians and blessed with amazing hands for surgical work. Promise to be have a chairpersons for these talks and run this show smoothly. That is, welcome Chairperson Dr. Sarabjit Singh and Dr. Manish Bhayati. Now our friendship story continued. We wanted some solid academic friends for the panel. And as you know, the friend is a friend on whom we can depend for his or her support. And really we are blessed. Dr. Manjusri Book, Dr. Anju Mathur, the amazing friend and wonderful yar, they know how to fill up the colors and design the panel and took the great pains for this panel on environment and infertility. So you all know, friendship is like a rainbow colors. So Dr. Pranita Chitnis, Dr. Shilpi Sood, Dr. Shalaka Mamidwa, Dr. Vinod Agrawal, Dr. Indrani Hatwar, Dr. Chirag Gupta, from different parts of India, they are going to fill up with the academic bliss. So welcome moderators and all panelists. लेकिन फ्रेंडशिप की डोर और डिस्कशन स्मूथली रनिंग की चाबी तो डॉक्टर निधि चांडक और डॉक्टर पायल अग्रवाल के हाथ में है, और वो भी प्यार को सबके साथ बांध लिए. Lastly, my co-conveners, Dr. Anju Mathur, a talented lady, Dr. Razvi, Dr. Nikita, then Dr. Archana Kumari, Dr. Bindu Chimote, Dr. Manish Bhaiti, all are in this friendly game. So I welcome you all. So friend is a friend, being with us all around, visible, invisible, offline, online, and we realized we are blessed. So just enjoy the webinar. Thank you.
Thank you, ma'am.
Okay, shall we move on?
Yes, yes.
Yeah. Okay. So let's move on for our topic of discussion, that is decline in sperm counts by Dr. Rajvi Mehta. For introducing Rajvi Mehta, ma'am, I would like to call upon Dr. Manish Bhayati. Dr. Manish Bhayati is a laparoscopic surgeon par excellence, and he is a director Shore Life Hospital and IVF Center, managing committee IAGE 2324. And he also has presented many papers and webinars to his credit. I request Manish sir to introduce our speaker, Dr. Rajvi Mehta. Is Manish sir here?
Sir, Dr. Caesar, Dr. Sarabjit is here.
Manish sir, have you logged in? I think he hasn't logged
We
in
just
yet.
asked Dr. Sarabjit is another chairperson. Dr. Sarabjit, are you there?
Dr. Sarabjit also hasn't logged in.
Okay,
I
then
think,
you continue.
Yeah,
Nidhi?
I'll introduce Dr. Rajvi.
Okay. Yeah.
I mean, it's always a pleasure to introduce
Okay,
Dr. Rajvi
sure.
Mehta, among the most senior and most experienced and most knowledgeable of embryologists of India, having worked right from the days of the first IVF baby with Dr. Bob Edwards. And she is here today as a convener of holistic medicine also. We know her penchant for yoga and meditation and everything, along with her passion for embryology. She is one of the first doctorates in human IVF in India and a PhD in human IVF from ICMR's National Research on Reproductive Health, and she has a vast experience. I mean, I'll fall short of words to explain her dynamic personality, but without wasting much time, and also because today she's going to deliver her lecture from the airport. So over to you, Dr. Rajvi, and we are waiting to listen to all the lovely your lovely talk today. Thank you so much.
Thank you, Dr. Bindu.
Thank
And
you.
yeah,
Ma'am, I'm just stopping my slides. You can
Yes, yes.
Sure.
Please.
Yeah.
so thank you, Dr. Bindu. Thank you, Dr. Sushma. The topic I'm talking about is about decrease in sperm counts, and it's something which has been bothering uh, all of us. I must say, all of us working in this field of infertility do not even need any data to see that there is a decline. Everybody knows that male infertility is rising. And even if you look at the publications that are being there over the years, you see that the number of publications in male infertility are increasing so high. And what are we doing about all the increase in male infertility? We try to treat the male, which is also, I would say, it's quite minuscule. We try to bypass male infertility by doing any of the assisted reproductive technologies. And then we are working on how to improve the selection of sperms so that we can have better outcomes of the ART procedures that we do. But I think it's time that we start thinking seriously of why is this increasing. I mean, while we go on treating, the rate of decline is quite serious. And I think we need to start thinking of the why there is this global decline. And we do have some generic ideas. And first is, yes, there is no doubt. Is there a decline? Yes, 100% there is a decline. Now, if you look further, when did this all start? The thought of looking at semen analysis and sperm counts went way back in the 90s with this paper in the BMJ where they talked about decrease in semen during past 50 years. This paper underwent a lot of criticism because the purpose for which analysis was done 50 years before and 50 years later was very different, and there was no way one can compare and come to conclusions that yes, there was a decline. And what they did report after a meta-analysis was that it nearly reduced to half. But then the truth is, the 50 years earlier, the analysis was done in men undergoing vasectomy, and the purpose was not for fertility assessment. So although this paper did not really establish what its title said, it made a lot of people look at their own data. And I must admit that we were one of those who started looking at sperm concentration. And I'm talking historically going back to a couple of decades. And we also found that there was a decrease in sperm concentration. It was the same lab, same technician. So we didn't anticipate much difference in the methodology, but there was a significant difference. And what was happening then was that there was just an increase in the construction and particulate matter. I'm talking of a time where, air pollution was not really thought about much, and there was a corresponding increase. It was a simple association study. One cannot really say that it was the cause and effect. However, we also found a very significant correlation, negative correlation between the concentration and SPM. Data was published. It was association we could not really pinpoint and say it was there. We did make an attempt to study this, but it was not possible. How do you study the effect of, the specific particulate matter on the thing? However, many other people were also looking at it, and we had this brilliant study from Greece, which showed about a significant decline in the volume and concentration over the years. And it was associated again with a marked deterioration in air quality in that area. So going further, the idea was that if you could look at specific group of people, and we ourselves were very excited, and I personally was excited to see if people who were exposed, like traffic policemen who were exposed to high concentration of air pollution, whether their sperm count should decrease, but we never managed to get people to volunteer. However, it was heartening to see that a study came in from Italy where they looked at toll booth workers who were constantly exposed to traffic fumes, and they found that total motility, forward progressive motility, the functional test, and even all the sperm kinetics were lower in toll gate workers, were the people who lived in the same area, clearly establishing a kind of association. And they also found that there was a high DNA fragmentation in the sperms from these people. So from just an observation, a good association was determined. And the cause for this was also associated with higher DNA fragmentation. Then one goes further, and a meta-analysis done about 2 years ago showed that now there were many more studies from across the world, which clearly showed that air pollutants at higher level were associated with impaired semen quality, including sperm concentration, sperm count, and declined total motility. So once this was established, the next thing was, how does it affect? I mean, air pollution affecting the lungs is understandable, but how does it really affect the reproductive system? I mean, it was a little difficult to comprehend a potential mechanism, but what they did in an experimental model in the male mice, they constantly exposed these mice to diesel exhaust particle, which is primarily would be the suspended particulate matter, and they found their fertility was impaired. And as it was determined in the human association studies, they directly demonstrated that count and motility also decreased. What was very interesting, that when they did immunohistological staining, they found that the exposure to these particulate matter prevented the repair of the double strand breaks in the DNA, affecting spermatogenesis, explaining the movement towards oligospermia and altered expression of testicular genes. Now, this was something which was a experimental study, not just a mere association, which showed a compromise in DNA repair mechanisms and also gene expression, explaining why there was oligospermia. So the association between air pollution has now shown to a possible mechanism. Now, while we are extremely concerned about air pollution and human health, I think it's time we concern about the transgenerational effect. If we move forward, again, a well-known culprit is pesticides. And it is one of the most suspicious agents. We know it as an endocrine disrupting agent. And the worst part is that it accumulates in human adipose tissue. And with obesity on the rise, we are going to have humans being exposed more and more to the accumulated pesticides in their own body. And we know the mechanism because they behave like estrogens. And especially during fetal exposure, there is decreased FSH. And because of decreased FSH of the male fetus, there is low spermatogenesis. So we are getting compromised, reproductively compromised children. Now, many studies, and the worst study was a huge study, 26,400 men exposed to dibromochloropropanone, and as applicators, 64% of these men had azoospermia or oligospermia. And if you look at it, it was a large number. What is very sad about this particular study was that this compound was banned in the USA, but it was utilized and used in the Philippines. So it is, when we know that a product or a chemical is harmful, I think it should be universally stopped in all the countries. Because if a country knows and they export it to another country, I think is a serious cause of concern. We cannot be indifferent to the health of fellow, maybe they're not your citizens, but fellow human beings. So this was, again, clear explanation. And let's not, we say we are not working in farms, we are not exposed, we are not applicators, we are not working in the pesticide industry, but we are exposed to this to the food chain. I mean, whatever we consume has been exposed to pesticides, and we know about this. Another thing that we need to bear in mind, that the use of pesticides in another form is there in urban India in a big way, because we are using these at home to prevent, the insects, etc. So we use those insecticides which are known to be toxic. And today we have a trend in urban societies that, we pay for a contract and then we say, okay, come and do the pesticides at my place. And there's a human mentality that we've paid for it, so let them come and do it, even if we need it or not. Because we have a contract for 4 such applications. And it's something that one needs to seriously concern, that if we don't need it, why are we using these? If we need it, surely do use it. So we need to give some thought to, a more of education where people believe they're organic. I can tell you the companies that come and say, they come and tell me, that, oh, this is organic. I said, but it's written, it's a chemical here. They will say, no, it is herbal for the human beings, but chemical for the insects. So this is how they try to convince people to use these. And we do know that they have a massive transgenerational effect. So here you can clearly see of the various components which are having a transgenerational effect on the testes. The worst is the plastics, then comes the pesticides, and then of course the other jet fuel, etc. But then not as many people are exposed to it. So the third culprit, the pollution, pesticides, and the third P is the plastics. Now, bisphenol A, I mean, I don't think there would be any day in our lives where we are not exposed to plastics. We cannot live without plastics. And possibly there's no body fluid which is not containing microplastics. So it has just become a part of our system. And whether we directly use plastic or not, it is there in the can linings, esters of phthalic acid is there. And plasticizers are constantly used to increase transparency, durability. And worst is the phthalates because they are not bound. So they're consistently released. And, if you think of it, our bottles of water, 30 years ago, I mean, if we start seeing the trend in the drop in sperm counts coming from the 90s, it's at the same time that bottled water entered India in the 90s, early 90s, and became part of our lives from mid 90s to late 90s. And we do know that they leach. We may buy high quality plastic containers, but our Indian food contains oil, ghee, and this you find leaching and coloring the plastic, and the plastic also would be leaching into our foods. The concern is that, again, it was shown in animal studies. So I'm bringing to you whatever data is this, and then experimental studies which showed clearly that bisphenol A, even a short exposure at birth, affected sexual maturity, sperm counts were lower. And adolescent exposure decreased sperm count and caused DNA change. Now the concern is, what about infants who are fed milk and water in plastic bottles and which are even warmed? So the feeding bottles, water bottles, especially to young boys or adolescent boys, are they contributing in any way? Because it's just normal now to consume water from plastic bottles. And the greater concern is this infants who are often provided milk through the feeding bottles. It's something we need to give, possibly bring about a lot more education than what it is. And if you look at the current world data, is it restricted to any part of the world? No. If you look any part of it, even in donors, where you expect things to be better, there is a drastic reduction. Whether you look at USA, they say it's constant, but it's looking over 20 years. Secondly, there is a lot of geographical variation. If you look at Northern Africa, considered to be, at a point of time where we didn't really think, that infertility is an issue. There is decline in all the sperm parameters, and these are recent studies in the last 4 to 5 years. We are not quoting old studies. And published data from Europe over 50 years show a 32% decrease. So this is quite a serious thing, even if it is not technically oligospermic or yet, but we are heading towards it. And my concern is that we need to address the cause for this while we continue treating these patients, because the effects are transgenerational, and this is something which is visible. We don't know what other harm it is doing. So even if you look over the years, you can see the drastic reduction in the total sperm count across the age groups. And you can see that this trend is sort of increased in 2003, 2004 onwards. And we do know that the rise. So Jatin is here, and I'm sure in the late 80s and early 90s, we never anticipated that infertility treatment and IVF would be so big in India. Of course, there was a demand, but I don't think we anticipated that it would be the way it is today. That the kind of need for infertility treatment, it's just unimaginable. So the thing is, and the last thing is the change in sleep-like pattern, which is just totally changed. Earlier, it was only people who worked in those professions where they had to do night duties. Today, irrespective, you find that, the smartphone is a part of our, I would say, an extension of our body. And here too, they have found some correlation. So every study starts with some associations and correlations. Then there can be experiments which show the possible mechanisms. And I think we should not just be waiting for that. We should proceed ahead. So sleep duration also correlated with sperm and total progressive motility. So basically, it's all about lifestyle. Some are in our hands. Some of these lifestyle factors are not in our hands. But I think as individuals, but cumulatively, yes, we can all work with it because we're talking of pollution. It is a cumulative effect. Pesticide use, utilizing, like I said, urban pesticide pollution, it is possible on an individual level. But I think if all the individuals come together, we can make a difference. And I think it's societies like ours, people who need to do more of awareness and educational, because I'm sure every individual wants to be healthy and wants their subsequent generations to be healthy. Otherwise, I think we'll be in a situation where we deny this aspect, like climate change. We never, it was known for a long period of time, but it was never considered something which is a serious thing. And today we see the impact of climate change worldwide. And are we going on a similar line? I don't know. So I think when we are seeing these trends, we are seeing this all over the world, it's time that we really look into it. So I think the 3 Ps, which are a major cause for the global decline in sperm counts, pollution, pesticides, and plastics, we really need to take our environment seriously. It is not just we talk about epigenetics, our environment determines us. We are not individuals who can live alone. So if we don't take it seriously, this environment is going to destroy us. So what we consider progress is going to be a downfall. And I think we need to continue doing talks, whatever we have now, these major tools of social media to alert society about the pitfalls of this. And finally, I think a progress itself, because all these P's are an outcome of our so-called progress, may lead to a downfall. So I'm not saying we don't progress or we start living in the Stone Age, but at least we start alerting people so we don't totally use this all the time, and we can ways and means to remove. Like recently, there are some papers that have come of removing nanoplastics from drinking water. So I think we need to look at a more holistic approach to this. So with this, I end my presentation. Yeah. So that's it from me. Any comments?
Very nice, Rajvi.
Yeah. Okay, thank you.
It was good. Very nice.
Thank you.
I think it
Great
is.
job, Rajvi. Safe flight.
Yeah, doctor, it's a
Yeah, I have to.
But
think-
the very fact that WHO has come down from 100 million to 15, 20 million per ml count speaks about the decline in the quality of semen parameters. And one more
Actually,
thing,
sometimes I would also wonder, because with all due respect to WHO, that how did they come to figures of 40 million at some point of time, or 60 or 20? I mean, it seems like very abrupt figures.
yes.
So I don't even think they have looked at it very seriously.
But
You know?
okay, nevertheless, we have seen a decline irrespective of publications, research, but we, in day-to-day practice itself, over the years, we are seeing a decline in the semen parameters. And it's high time we need to wean ourselves of all the plastics and pesticides that we are rampantly using. But in the meanwhile, what is it that you would suggest that as a reverse, I mean, can we reverse this effect somewhat by making lifestyle changes? So what are the lifestyle modifications that need to be made to reverse this process even a bit, apart from, of course, weaning ourselves off?
See, I think weaning off would be impossible because these are part
Not
and
completely,
parcel
yes.
of our life. But
Yes.
I would surely say that if we can alert ourselves, there are a lot of things which are not necessary and we will possibly get out. So something new, relatively new we've heard about is the sleep patterns. Now that is in human hands.
Yes.
And that is something we can work on, educating people about it, things like that. Even if you're talking of toddlers having plastic milk bottles, that is something can be stopped immediately with a lot of education by the pediatricians, gynecologists. So I think small way we can make a beginning and shift over. So
Yeah, at least we can avoid using plastic water bottles.
yes.
Because it's basically actually plastic is actually at everyone's house it is decorated, the plastic material is there. So day by day we are bringing so many pollutants at our home, we really don't know.
So we can't go the extreme, but at
So
least we can make
everybody
a
should
small
know,
bit
but
by bit.
everybody should know, because that's why the detailed history is very important. I think Dr. Manish has joined. Dr. Manish as chairperson, do you want to say something?
Yeah, Dr. Manish is there, and I
Yes.
think we should
Dr.
not
Manish
waste much
Bharti?
time. We have
Yeah, we'll go ahead.
Dr. Jatin Shah with us.
Yeah, we'll go ahead with the
Manish?
Dr. Jatin Shah.
Yeah,
Dr. Manish?
Manish can introduce.
Yeah, I wanted to say, few years back, Dr. Rajvi, I had been to camp near Bhandara, and I had seen during that my camp, I must have seen somewhere around 40 or 50 patients, of whom I can very clearly say 60% were azoospermia. And I was shocked, and I discussed many times with people why this segment is so. And there are so many right from Balaghat, Tumsar, Bhandara. This is our area near Madhya Pradesh, where we are seeing the sperm count has decreased to zero, azoospermia, and it is happening and nobody is taking care of. So somebody has to either inform our government and make aware about it if this thing is coming into picture. That's what I feel.
True. I think so. So it's not just public. I think the
Necessary.
authorities need to be
Authorities need to be aware. They are not aware about these issues, and that must be the reason they are not taking cognizance of it. Unless until we all, as a members, make
Yes.
things aware about, they might be ready to do certain changes.
Sure.
Yeah,
I think
let's
that's
go
a
ahead.
topic for another webinar where we
We'll
can
just
really
discuss
brainstorm.
yeah, we are having webinar also. We'll go ahead.
Thank you. Thank you so much, Rajvi ma'am. It was wonderful, eye-opening talk and such a thought for discussion further and next webinar topic.
Thank you.
Yeah. So, Dr. Sarabjit sir, I think has not logged in, ma'am. Bindu
Dr.
ma'am?
Manish is there. No?
Yeah, Manish sir is there. But then,
He can introduce, no, Dr.
yeah, I'll just
Yeah.
introduce sir, and then I request Manish sir to kindly introduce Jatin sir.
Yes.
Yeah. So thank you so much again, Rajvi ma'am and Manish sir and Bindu ma'am for doing the introduction for the ma'am. Now we'll be moving to our next topic, which is environmental factors affecting ovarian reserve and tips for management. So we just saw that how environmental factors are affecting male factor. Now it's turn for a female. So for this wonderful session again, we have our eminent speaker, Dr. Jatin Shah sir, and our chairperson for today is Dr. Sarabjit Singh sir. Sarabjit sir is a reproductive medicine and obs-gynae consultant at Sarab Healthcare and IVF Center, Jalandhar. He is a medical director at Dove ART Bank, Jalandhar. He has been a past secretary for IFS Chapter 21. He has been a convener of SIG Andrology. He is treasurer and organizing chairperson and organizing member for many conferences like Fertivision, Fertility Concepts. He has delivered many lectures. He has many publications in his credit and even achieved a Best Paper Awards. So we welcome you, sir. And we would like to request Sarabjit sir and Manish sir to kindly introduce Jatin sir. Over to you, Manish sir.
Yeah. I am obliged and honored to introduce our boss and best stalwart in field of ART, Dr. Jatin Shah. I can just read out his achievements that he has successfully established pregnancies in more than 17,000 infertile couples. In 1995, he won the best paper for topic IVF in tubal factor infertility. In 2003, he was awarded as Young Personality of the Year by Governor among 10 outstanding young Indians. Extremely well versed with IVF, IUI, oocyte donation, sperm donation. I think we are learning from sir since last 2 decades, not less than that. He's currently performing close to 2,000 cycles of IVF per year, and I'm sure there are so many IVF specialists. When the failure happens multiple times, we usually say find out. Some answer can be taken from Dr. Jatin Shah. We do refer to him all complicated cases, and he definitely comes out with a result. Thank you, sir. Welcome, sir, for this webinar.
And if I may add one point, his secret of success is that he has an eye for detail. An eye for detail, not just in ART. That is why his photography is so wonderful, because he has that eye for beauty and detail. So yes, over to you, Dr. Jatin Shah, sir.
I have seen his photography, and they are outstanding.
Thank you so much, Manish. Thank you, Bindu, dearest Dr. Sushma, Rajvi, all the organizing members. I'll just share my screen. Where's the screen going?
Any problem, sir?
Any
Yeah,
problems? Yeah.
just put me back in. I don't know why it's like just happened. Could you see the slide?
No, no, we
The
can't
first
see.
one, yes, when you had
We
shown
have
the
seen the first one. There's the
AFS
environmental
ovarian reserve,
factors. Yeah.
that's
Yes.
you could see.
Okay, I got it.
And the group 1, group 4.
Yeah. It started, sir.
Now we can't see.
No, it'll come.
Yeah.
Yeah, okay.
Yes, okay.
Yes, sir.
Thank you. So that was a fantastic talk by Rajvi as usual. And for a lot of you who don't know, Rajvi and me go back almost 35 years. In fact, we were together, when India's first, one of the first IVF babies was done at KM Hospital in Mumbai. And she is actually responsible for teaching me a lot of my embryology skills. I still remember, we used to wash the lab together. She used to teach me about incubators. We just had this one large refrigerator-like incubator in those days. And we had to, dechromatize glassware. We didn't have any disposables, nothing of plastic available. We had only glass, petri dishes, test tubes, which had to be reused, washed. Then she used to make me run to Wadia Hospital to collect cord blood so that I could extract protein. And then we had to make our own culture media. So these were the days, when we really learned all the basics of IVF. And she was there as a solid rock with us during the IVF program, not only when I was a research fellow at the IRR in Bombay, but even after that for 3 years when we started one of the first IVF clinics at Bangalore. So that's how, how good Rajvi was and still is at embryology and especially basic science. She has a lot of publications and I'm sure all of you know that. Sushma, of course, thank you so much for always giving me a very difficult topic and for always giving me the best introduction ever. I just love the way you do that. And I wish I could invite you for every webinar to just introduce me also. And Bindu, of course, I wait for her on Facebook because I know I write these small poetry and captions and quotes, but she's the one who always adds the last touch of class by writing one more quote in the comments. So thank you, Bindu, for that. And ladies and gentlemen, of course, today we are a very, very important topic. And when she first told me to talk on environmental factors, I said, who talks on environment and who would be interested in environment? So I said, no, I'm not talking on environment. I'll only talk on management of the poor responder. Then I said, let me do some research because the whole theme of the meeting is environmental influences. And believe it or not, for the last 2 weeks, I have come across more than 200 papers on every possible environmental influence on ovarian reserve and poor sperm quality. So it's high time we don't just take the kind of activists like Greta Thunberg and all of them very lightly. We need to be very serious if we are worried about our generations to come, for our children and our children's children. It's high time that we wake up and take notice of environmental factors. So what is the evidence for that and why is it so important? I'm sure all of you agree that if you look back at your IVF practice, more than 50% of your patients will be one of the poor responder groups of Poseidon 1, 2, 3, or 4. So 1 and 2 are, of course, young and old patients who came to you with a normal ovarian reserve, but yet they did not respond the way you expected them to. So you have a subgroup 1A with less than 4 and subgroup 1B with 4 to 9 oocytes. That, of course, a lot of them are iatrogenic, so we'll discuss them later. But we have group 3 and 4, which are young and old patients who came to you with a low ovarian reserve. Now, why do we have this low ovarian reserve even in a 28-year-old or a 38-year-old or a 30-year-old? And then they ask us, doctor, how is it possible? I'm just 28 and you're saying that I've lost my egg reserve. And this is where we need to go back to when she was in utero in her mother. And today I'm going to show you data that it's not just our environment currently which affects all the young girls who are existing today, but it begins right when she is in the womb of her mother. So the mother has to take so much care. Every pregnant woman has to take so much care to make sure that her female offspring is not born with a diminished ovarian reserve because of environmental and some preventable factors that she could have taken care of. So all of you know this slide and you know that the number of non-growing follicles are the highest at birth. You can see the green line clearly showing there are so many follicles when a female child is born, and then there is a steady decline, and by the age of 30, most girls have lost 88% of their egg reserve. And then of course there is a further decline which goes on until menopause. And you also have an increase in the number of abnormal oocytes from the age of about 35, 36, steeply increasing after the age of 40. And on a lighter note, I'm sure that scientists will not be far away from, just like we do cord blood banking of a newborn baby, Maybe they'll find a way for us to do ovarian tissue cryopreservation at the birth for a female child, so that to make sure that we completely eliminate this problem of poor ovarian responders in the future. But of course, those days are far away. And what do we have to estimate reserve? And of course, all of you love AMH, and so do I. And it's the best predictor of ovarian reserve and often a good predictor of IVF success as well. And of all the 4 Poseidon groups, the one which really is a bulk or a majority in our clinics now is the Poseidon 3. So we are talking of young women who come to us with a low ovarian reserve. So we know, of course, that AMH will be reduced if there is a history of ovarian surgery, endometriosis. Currently, the woman is smoking or vaping, if she's taken chemotherapy, if there are low vitamin D levels, and a lot of other reasons. It's increased in PCO and in granulosa cell tumors. Interestingly, what doesn't have an effect, which we sometimes think it does, if there is a history of past smoking, if the socioeconomic status is not too good, current alcohol use, physical exercise, BMI and obesity and race. So these are some factors. As of today, there is no evidence that they really reduce the AMH levels. So what are the contributing factors for a decline in the oocyte pool? You have internal factors such as oocyte attrition, follicular atresia with advancing female age, and meiotic errors. These are unavoidable and will happen. External factors, you have environmental toxins and medical treatments, which can either trigger internal factors or directly cause a decline of the oocyte pool. We are not just talking numbers, and there are a lot of factors which even affect the quality of the oocytes, which we know is often a major problem in IVF clinics. And part of this, of course, we know the PCOS and insulin resistance patients often have poor oocyte quality. We also know that with aging, there is an unavoidable a decline in oocyte quality. So also diet, increased lipid and increased leptin. But today's focus is going to be on environmental factors and the endocrine disrupting chemicals and how they play havoc with oocyte numbers and quality. So let's begin with going back to when the female child is in utero, and what are the factors in a mother who is expecting which can cause a decline in the ovarian reserve, not only for her female child, but maybe even for her granddaughter or so. And is this really possible? Do we have evidence for this? So remember that the ovaries of a newborn baby contain approximately 1 to 2 million of non-growing follicles. The count of these follicles and even oocytes later decreases with follicular atresia, apoptosis with aging. So it's very important to remember that whatever an adult woman, the ovarian reserve which she achieves before birth is going to determine her later ovarian reserve. And what are these maternal factors which will affect ovarian reserve in the female offspring? Remember, all of us are giving a lot of DHE and testosterone to a lot of IVF patients with poor response. Sometimes inadvertently, if the mother happens to continue the gel thinking it's a very innocent thing to do, or a DHEA capsule, you are likely to affect the female offspring and reduce her ovarian reserve. Excessive weight gain during gestational period, smoking during pregnancy, exposure to aristolaucic acid and D-galactose, these all will contribute to reducing the ovarian reserve of the unborn female fetus. Maternal malnutrition. Again, this has been correlated with smaller sized ovaries in the female child. Protein restriction, low protein diet also impairs germ cells, primordial follicles, and reduces the number of follicles. Excessive maternal caffeine intake, again during pregnancy, is negatively associated with the ovarian reserve in the offspring. And did you know this, that the effects of inadequate protein intake may persist for 2 generations or more? So you will have a granddaughter saying that, oh, how come my mother also had a very low reserve and got an early menopause? Maybe the grandmother did not have an adequate protein diet. So it is now known that low protein grandmother diets can lead to diminished ovarian reserve because of a rapid decline in ovarian telomere lengths. Socioeconomic factors which can cause diminished ovarian reserve. Again, exposure to unhealthy behaviors, polluted air is one of the most important. Poor living conditions in socio-economically disadvantageous areas. All these can result in an unsuitable intrauterine growth environment. Exposure to high environmental temperatures. Now, here again, I'll show you a slide subsequently that too much of heat and areas which are really warm and hot, reaching temperatures of 40-45 degrees. If a mother during pregnancy is exposed to such temperatures, this also could reduce the number of follicles in the female fetus. What about smartphones during pregnancy? Again, this was a wonderful study in 2019 that mice exposed to radio frequency radiation had significantly lower mean number of primordial secondary follicles and a higher score of atresia. Luckily, this can be offset with omega-3 supplementation. So I'm sure a lot of you do already give omega-3 supplementation to most of your pregnant mothers, and this has been shown to be protective against excessive cell phone use by a pregnant mother during her pregnancy. So this summarizes all the maternal factors: smoking, high gestational weight gain, high ambient temperatures, malnutrition, high sugar and fat diets, excessive caffeine and intake or exposure to testosterone. All these during pregnancy are not good for the ovarian reserve of the female fetus who is yet unborn. Moving on then to environmental factors which can cause diminished ovarian reserve during the woman's life. And here we have to remember, as Rajvi pointed out, that environmental pollutants are the most important, and they generally affect the ovarian reserve in three ways: either excessive oxidative stress, epigenetic modifications of which we still know very little, but most importantly are the endocrine disrupting chemicals which really play havoc with the ovarian reserve and the oocyte quality and oocyte maturation. And it's not only reproduction. You can see exposure to these EDCs affect practically every system from head to toe. So whether it's the brain and the nervous system, the cardiovascular, the GI, the metabolic, or the reproductive, and also predisposition to cancers, everything is increased with exposure to these EDCs. And what are the possible mechanisms of these EDCs on the ovaries? You can see here just from this drawing that it practically affects every type of ovarian function. So you have a direct stimulation of androgen synthesis, decreased level of gonadotropins, potential upregulation of the GnRH pulse generator activity, displacement of sex steroids, disruption of oogenesis, and so on and so forth. So practically every kind of step in the metabolism in the ovaries and oocyte generation is affected by these endocrine disrupting chemicals, especially bisphenols, parabens, and triclosan. So how do these pollutants come in? And most important is in your daily drinking water and food. So drinking water, especially where you have organic pollutants and pervasive contaminants, you have food, especially where too much of fertilizer and pesticide has been used. And of course, the biggest culprit of them all is your daily plastics, which we are all the time exposed to. You also have the PFASs and you have the MCPDs, all which can cause aberrations of follicular development and promote ovarian fibrosis as well. Phthalates, of course, are the most important because they are used for manufacturing plastics and pesticides. And you can see a study clearly showed 215 infertile women where had the higher urinary phthalate levels, means they were exposed to too much of plastics and pesticides, definitely revealed a decrease in the antral follicle count. Also, it was found that their follicular fluids had reduced corticosterone and cortisol levels in these women were found. So you have enough evidence now and studies now to show us that all this is just not hearsay and rumors and just the talk of a few environmentalists or activists, but this is all now a huge science. And it is really nice that all of you have got together and formed these societies to deal with this and at least create awareness of why we should be paying more attention. Inadvertent exposure: a lot of women may be at their workplace or in factories or in the fields exposed to arsenic or bisphenols or fenvalerate or insecticides and herbicides, all of which will reduce in a diminished ovarian reserve. Inverse relationship has been documented between outdoor air pollution. The higher the outdoor air pollution, the greater is the reduction in antral follicle counts and AMH. And as I told you, ambient heat. With an increase in the ambient temperature of 1 degree centigrade, antral follicle count decreases by 1.6%. So all these factors put together are very, very important. Besides the environment, you also have psychological factors: women working very hard, very long, handling heavy objects, women who are prone to depression, anxiety, neurosis, and stress, and also fatigue, anxiety, despondency, or tension, all have been shown to be associated with a diminished ovarian reserve. Contraception, somehow I didn't agree with this particular study because we know that the suppression of AMH levels with an OC pill are just temporary. They do not represent the real and accurate AMH levels of that patient. If she discontinues the OCP and checks her AMH after a month, most often the AMH level will come back normal. But however, there is a study which says that maybe prolonged contraception too can be a reason for diminished ovarian reserve. Finally, which is really alarming me now, because every fourth or fifth file that I come across Even the female partner gives a history of smoking or vaping, and this is where we really need to pay attention. Now they take it too lightly. Remember that smoking will cause infertility. It impairs most of the ovarian follicular dynamics, induces a lot of gamete and oocyte mutations, also increases the risk of early miscarriages and IVF failures. So also excessive alcohol consumption can cause altered hormone concentrations, hindering ovum maturation, disturbing ovulation, and resulting in poor implantation rates with your IVF. So a lot of our young generation thought, oh, no, cigarettes is out. Let me do something which is safer, and that is let me resort to e-cigarettes or vaping. Remember that these are probably worse. At least with cigarette smoking, we have research over the last 100 years or more. E-cigarettes, we don't have any research more than maybe maximally a decade or so. And although it was considered a safe substitute, remember that it contains, most of them contain more than 80 compounds besides just nicotine. And we have no studies to show the toxic effects of these chemicals on oocyte reserve or smoking, but I'm sure they are going to be more harmful than conventional cigarette smoke. And the companies proudly come out with generation after generation. And you can see here, now they claim to have a fourth generation of e-cigarettes to substitute conventional smoking. But you can see here that e-cigarette mediated reproductive disruption is severe both in the male and in the female. So it is known now to alter uterine receptivity, cause mutations in oocytes, increase the risk of abortions, and maybe abnormalities in the babies which are born if the mother has been vaping before, immediately before or during her pregnancy. We also need to pay attention more and more to microflora, vaginal microflora. At this time at ESHRE, there was half a day of sessions which were just dedicated to vaginal microflora, and they've shown that actinobacteria, atopobium, and Gardnerella were all negatively associated with AMH levels, inhibin B positively associated with FSH and LH, whereas bifidobacterium levels were positively associated with AMH and negatively associated with FSH and LH levels. What about autoimmune disease? And we know that in SLE, there is a decrease in AMH and antral follicle counts and ovarian volume as well. The earlier the patient or the girl has started treatment with cyclophosphamide in childhood, the lower are the AMH levels. And also remember that exposure to and accumulation of cyclophosphamide affect ovarian function and lead to diminished ovarian reserve in women with SLE. The same also for rheumatoid arthritis. Patients with RA have lower AMH levels, and these are more likely to be caused by IL-10 and other inflammatory factors. So this summarizes most of the internal and external factors. You can see here follicular fluid changes, vaginal microflora, autoimmune disease, contraception, and of course, psychological issues. But our main focus was today on the environmental conditions and the various chemicals and EDCs, which are responsible for a diminished ovarian reserve. There is also a very recent paper showing that diminished ovarian reserve, there is a likelihood that the risk of DOR increases if there are higher overall concentrations of alkali and alkaline earth elements in the follicular fluid. And among the 9 detective elements, they have found that potassium, lithium, and caesium exhibited significant individual associations with diminished ovarian reserve. So more and more research, the idea of just touch and go on each of these research papers is to show you that how much research is now happening on the environment and chemicals and all our other influences on diminished ovarian reserve. As we heard earlier, even excessive exercise can lower female fertility by damaging ovulation, endometrial development, and sometimes inducing prolonged amenorrhea. Circadian dysrhythmia, especially sleep disturbances, also gaining more and more prominence now as being able to interfere with fertility, altering the secretion of reproductive hormones, impairing reproductive outcomes, and or increasing inflammation. So we need to pay a lot of attention and not just tell, oh, it's okay, just count sheep 1 to 100 or take a melatonin. You know, we need to get into sleep disturbances and make sure that we treat them at the earliest to prevent a further loss of ovarian reserve. And one good news slide for all. Please remember that they have finally established that there is no association between low to moderate intake of mild alcoholic beverages, a little bit of caffeine, sugar sweetened and artificially sweetened beverages, and antral follicle count. So specific beverages such as coffee, tea, soda, beer, wine, or liqueurs, except hard liquor, most of these are generally safe and do not interfere with the diminished ovarian reserve. So a glass of wine here and there is okay. I'm not promoting it, but maybe as this paper shows, it is not going to do so much of damage for you. Again, coming to mobile phones, during lifetime. Initially, I showed you when a pregnant woman uses too much of mobile phones. And again, we now know and have study from 2017 that mobile phone exposure reduced the number of follicles in the ovaries of the pregnant rat and may cause endometrial apoptosis and oxidative stress. So it affects both male and female fertility because these are microwave emitting devices and they will have their adverse effects, especially if you keep them close in your pocket near the genital area or in your purses, or you use too much of mobile phone all day long. You know, a lot of people have screen times of 6 to 8 hours, talking times of 3 to 4 hours a day. This needs to be checked, especially if you're in your reproductive age group between 20 and 40. So that brings us now to tips and tricks for managing, which I've shortened a bit because I had to talk so much on environment. And of course, we already know what are the Poseidon 1, 2, 3, and 4. And bringing us to management, you have to remember one thing, that Poseidon 3 and 4 is not going to give you too many eggs. So you have to remember that you must try to get maximum eggs from these patients. You want that if you can get instead of 3, even 5 eggs, it is going to make a huge difference. You can see here, you need at least 3 mature oocytes on an average to get 1 top quality embryo in a patient. So this is the ratio that you need for poor responders. Does it really count? Yes, you can see here with every additional oocyte that you get, there is an increase in the live birth rate of the patient. So how do you go about establishing oocyte numbers? I will come to shortly. More important than numbers, we want competence. We want good quality embryo, even if it's just 1 or 2 embryos, to maximize the live birth chance. So why is oocyte competence more important than oocyte numbers? And this study brings that to light. You can see here this study of 40,000 cycles comparing endometrial thickness with final pregnancy outcomes in fresh IVF transfers. What is noteworthy, that even in the range of 5 to 6 millimeters, the group still showed a live birth rate of around 20%. So although we know that, of course, 8 to 13 is the best and so on, it is not that 5 to 7 is going to give you a 0 pregnancy rate. So this exactly proves the point that when it is made, that if we consider a pregnancy as 100%, the contribution of the sperm is probably 10%, the contribution of the uterus is probably 10%, but the egg contributes 80% of a final pregnancy. And that is why the competence of the egg is of paramount importance when you are doing a successful IVF program. So how do you go about managing your Poseidons 1 and 2? Of course, we know the common causes are you started with a lower dose than she required. Many a times we tend to give 150, 187.5. I still don't understand in today's world of the antagonist with the flexibility of using the agonist trigger, why would you underdose? But still it happens. Basic thing is that do not start with a low gonadotropin dose. Second, of course, the presence of polymorphisms or environmental factors, which we already listed in the first half of the lecture. Asynchrony is the most important. You know, very often a patient walks in on day 2 evening into your OPD or day 3 morning, and you start the gonadotropin in a rush. Remember that a lot of these poor responders, and now it is a proven fact that a lot of them, because they have very low feedback levels, there are high FSH levels, which actually begin in the late luteal phase of the previous cycle. So what does this do? The high FSH has already recruited the dominant follicle maybe a day or two before she gets her menstruation, unlike women who are normal responders. So when you begin on day 2 or day 3 and then call her on day 7, that follicle is already 14, 15, 16 mm, and your newly recruited follicles are still in the range of 8 to 10 to 12 mm. And this is called asynchrony. So you end up either getting just one mature egg, or you sacrifice that one large one and get the others, which are probably not as good as the best and the fastest growing dominant follicle. So synchrony is very important in IVF in poor responders. And finally, of course, the choice of trigger that you use so that you ensure a maximum conversion to metaphase to oocyte. So how do you go about that? Your minimum starting dose across all spectrums, poor, normal, or high responders, should never be below 225. So 225 to 450 is what works best. Thin, lean PCOS, 225 is fine. Let her give 30, 40 oocytes. You give the agonist trigger. She is not going to have OHSS. You do not have to give keberlins, letrozols, albumins, or even call her for a checkup. The next day, the ovaries are going to be back to normal. So you can see here the studies which clearly show you get more oocytes with 200 versus 100, more oocytes with 225 versus 150, and maybe no difference between 225 and 300 for normal or high responders. Again, I cannot stress enough, because despite my teaching this for the last 5 to 10 years, the importance of follicular synchrony, we still find that patients are started on FSH without any pre-treatment in an antagonist cycle. So what are the various pre-treatment strategies that are available to us? The number one, and all of you need to go back to what we were doing 35 years ago when we had only the long agonist protocol. Remember, the beauty of the agonist protocol was that because of the complete suppression, you never had a dominant follicle popping up until you didn't start your FSH stimulation. And that was how we could do batches. We could bring patients together, schedule them, because once they are downregulated, they are totally under your control. Of course, we were also using them for PCOs and normal responders, which ended up in OHSS. But we forgot, why did they have OHSS? Because the agonist protocol ends up giving you more oocytes and more embryos. But that's exactly what you want in a poor responder. So the agonist is the best way to get synchrony, to recruit more oocytes, and to get more top quality embryos. The only trick here is, do not begin with pure FSH. In a downregulated poor responder, the argument was, oh, she's already has a suppressed axis. Why do you want to suppress more? The trick is that FSH, LH both get suppressed when you do down regulation. So if you give only FSH, you do not have any endogenous LH to support follicular growth. So directly you can begin with 300 or even 450 of an HMG preparation to make sure that in 9 days the follicles are ready and they are all of the same size. So the best advantage is you get a synchronized follicular development. You can see here the poor ovarian responders study in 2019 with the agonist cycles. Number of oocytes higher, number of embryos higher, clinical pregnancy rate higher, and live birth rate almost double of the antagonist cycles. Another study from 2018 comparing Poseidon 3 and 4 versus non-Poseidons. And you can see here again, Poseidon 3, that is a chunk of our poor responders, young patients under 35, the agonist clearly gives a live birth rate of almost 30% as against just 16.7% with the use of the antagonist. And believe it, it is purely because you get better oocytes, more synchronized oocytes, more M2s, more embryos, and therefore you get a higher live birth rate per transfer. Also, there is a study to show that the agonist, in fact, has better endometrial receptivity. So those were the days 30 years ago, we used to do only fresh transfers, and yet we used to get the same 40% pregnancy rate that we get today, despite all our so-called claimed advantages of vitrification and frozen transfers and time transfers and eras and windows of implantation. The basic fact is that we are still struggling at 40-45%. So patients treated with the antagonist have a thinner endometrium. They have significantly lower Hoxaten expression in the endometrial stroma cells, and that is probably why the agonist is again better and gives you better live birth rates. Again, here there was a patient study in Poseidon 4 comparing agonist and antagonist, and they showed that especially patients who had an AMH of more than 0.7 on the long agonist protocol had significantly higher cumulative live birth rates than the antagonist protocol. What about an in-between compromise, and something which really needs to be rejuvenated? I feel I've just tried maybe a couple of patients now, that you are worried about excessive suppression, you don't want hyperstimulation, you don't want oversuppression. Fine, you have to just start the GnRH agonist, mid-luteal start, just as you do in downregulation, the long protocol. You wait for her menstruation, call her in on day 2, day 3, she is well downregulated. Wait for 2 days as a washout period. Then you begin your FSH or HMG. Then you add back the antagonist at 14 millimeters. And this you then continue till the day of the final trigger. So to put it simply, you can see here the agonist started first around day 21. She gets her menses. You have a washout period of 3 days. She will not escape down regulation in 3 days. You then start the gonadotropins. You then add back the antagonist at 14 mm and finally trigger at your normal with your normal criteria. The advantage is you get best synchrony, because you have utilized the down regulation agonist to make sure there is no recruitment of any follicle in the luteal phase. Also, it helps you in cycle programming. If you are doing 5 or 10 patients together, you can wait for the last one to get her menses. Avoids the need for higher gonadotropin dose. You know, the criticism of the agonist protocol is that because you have cut off endogenous FSHLH totally, you will need 75 IU more of exogenous, thereby increasing the cost of the cycle. You have completely abolished the premature LH surge, of course. You get a higher yield of mature oocytes. you still have the flexibility of using the dual trigger. Now, in the long agonist, you have to use only an HCG trigger. If you use the antagonist-agonist combined stop agonist-antagonist protocol, you get back the chance of using an HCG dual trigger, and you get significantly higher number of follicles, more mature oocytes, and top quality embryos with this. So we need something food of thought for everyone to maybe try this out for a few Poseidon 3s and 4s. And finally, of course, we have PPOS now, where again, we know that with PPOS, we have beautiful suppression of aberrant endocrine hormonal, aberrations of LH, progesterone, and so on in the follicular phase. And maybe this too will help you to improve your clinical pregnancy rates. This is the only paper which I came across where it is being used for poor responders. Otherwise, we know most of the papers on PPOS are for PCOs and for egg donors, where you eliminate the need for giving the antagonist, and you know that you can't do a fresh transfer anyway. What about other pretreatment methods? If you're still not convinced that you don't want to use the agonist or luprides and buserlins, then you still have other methods which you should use, like luteal estradiol valerate or norethisterone or the antagonist on days 2, 3, and 4. All these are beautiful methods of ensuring that you get a synchronous cohort. And why I already mentioned this earlier, that we know that there is an association between short cycles. Some poor responders have very short cycles. Maybe they are in the premenopause, perimenopause age group or the functional group. We know that as ovarian reserve decreases, so does the number of functioning granulosa cells secreting inhibin B. FSH production is subsequently increased in the late luteal and very early follicular phase, resulting in earlier follicular recruitment, very short follicular phases, and therefore asynchrony because you already have the dominant follicle racing ahead. So luteal estradiol, of course, I already spoke of, because after the agonist, my first choice or second choice rather is luteal estradiol, because we need to have synchrony. Very easy to do. You document ovulation. 1 week after that, you begin estradiol valerate. 4 milligrams is the key. You cannot give 2 or 6. 2 milligrams BD is all you need to give. Continue until she menstruates. Then when you begin your FSH or HMG dose, you can discontinue the estradiol valerate. Then add back your antagonist and of course proceed with the conventional antagonist cycle. Second important, or rather third agonist, luteal estradiol antagonist on days 2, 3, and 4. So if you want a very good synchrony without all giving agonist for too long or the OC pills, you just have to administer the antagonist on days 2, 3, and 4. This will suppress the dominant follicle, and when you begin stimulation on day 5, you will get your synchronous cohort. And as this study by Blockhill showed, number of eggs increases from 10 to about 14. And as I told you, every extra egg that you get is important. And of course, there is also talk of giving a luteal antagonist, again for the same reason, but sometimes you have to give more than 3 over here. And they showed significantly more metaphase 2 oocytes, higher M2 numbers, higher mature oocyte yield, more cleaved embryos, and higher clinical pregnancy rate of 22 versus 13%. So follicular phase antagonist is what I described in the earlier side, day 2, 3, and 4. You can also give luteal antagonist if you want to completely block the recruitment of the dominant follicle in the late luteal phase of the previous cycle. What about adjuvants? Of course, I don't want to go too deep into that because today's talk is more on environment and just tips for managing your poor responders. But what has evidence now is androgens, DHE and testosterone. Please be very careful that she discontinues many days before the embryo transfer for reasons which I showed you earlier. Coenzyme Q and growth hormone all are supposed to have very good outcomes. Some papers show that direct testosterone for 20 days is probably better than 3 months of DHEA. New interest being, coming back for growth hormone. You can see this paper from 2023 showing an increase in the clinical pregnancy rate, number of oocytes, and fertilization rates. But there are too many protocols. There is too much confusion, and the cost of growth hormone is pretty high. So we need to have a perfect regimen, perfect protocol. That should it be 4 IU, 8 IU, 12 IU? Should you start on day 2? Should you start in the luteal phase? Till what day do you continue it, and so on, so that we can start implementing it in regular practice. Supplements, the most important, which of course I use for each and every patient, and I'm sure all of you do, is ubiquinol or coenzyme Q, because there are too many research papers now clearly showing that it helps in regeneration, it helps in a lot of mitochondrial repair, and therefore it helps in restoring oocyte integrity. You can see this initial study from 2015. This is a young mouse ovary with nice primordial follicles. This is the old ovary, which is nice and shrunken and atrophic. And believe it or not, this is the same second ovary after 15 weeks of coenzyme Q treatment. So that is why coenzyme Q rates highest in the list for adjuvants for poor responders, followed closely by androgens, whether it is DHEA or testosterone, and followed by growth hormone. Most of the other recommended adjuvants do not have evidence of their being of any benefit. What about addition of LH? Of course, we know LH is mandatory for poor responders. So all women above the age of 35 from the beginning of stimulation, all women who have been hypo-responders, means the follicles have been stagnant from day 6 or day 7, you must start from the beginning in a subsequent cycle. Hypo, of course, you have to begin with 300 of FSH and LH. Anything less than that will not work. And all poor responders, you have a significant increase. And the most recent evidence for this is this paper from 2024, where they added 150 IU of menotropin along with long-acting recombinant FSH and tried to find out whether that helps. And you can see estradiol levels are better, you have fertilization rates which are better, and you have more blastocysts available for transfer and therefore a higher clinical pregnancy rate. Finally, of course, the trigger. Remember that dual trigger should be the way forward for all poor responders, because we know that although HCG has been our main trigger for more than 3 or 4 decades, HCG only simulates the LH peak, whereas in a natural, normal, physiological menstrual cycle, you have both FSH and LH surges in mid-cycle pre-ovulatory. So when you give an agonist trigger, you are mimicking absolutely what happens in nature. So you have surges of both FSH and LH, and that is further strengthened by the HCG which you have administered. And as this paper clearly for women with diminished ovarian reserve showed, higher clinical pregnancy rate, higher live birth rate when you use a dual trigger. Of course, dual stimulation, all of you used to like it. I used to love it. And at least personally, I have discontinued it for the last 2 or 3 years because I believed it didn't work. And now we have evidence that it doesn't work. So we had a lot of initial papers, very exciting papers, that luteal phase stimulation gives you more oocytes. Then you have luteal phase stimulation giving you more blastocysts. The blastulation rate is better. That the pregnancy rates are almost double with luteal phase stage stimulated embryos as compared to follicular phase stimulated ovaries, embryos. And even the obstetric and perinatal outcomes with FPS and LPS are the same. So we were all gung-ho about this. But remember, when we used to do our conventional ovarian dual stimulation, we used to give an agonist trigger in the follicular phase. And then after 3 or 4 days, we used to start the so-called luteal phase stimulation. Now that is where the twist in the tail comes. And if you look back again to basic physiology, remember that what does an agonist trigger do and why is it safe in PCO patients? Because you hardly have a luteal phase. Because with an agonist trigger, you have abrupt luteolysis, and that is why most of them menstruate within 2 or 3 days of the egg retrieval. But none of us thought of this very basic thing, and we were in a dream world that we are doing a luteal phase stimulation and getting better eggs and better embryos. So what we were actually doing, in fact, we were just doing 2 consecutive follicular phase stimulations. And the best way to prove this is that when she bleeds on day 2, just do her estradiol and progesterone levels, and guaranteed the estradiol will be less than 50 and progesterone will be less than 0.5. Now, if progesterone is less than 0.5, how do we label it as a luteal phase stimulation? It is just a day 2 again of the follicular phase. Also, with our conventional dual stimulation, we were forced to do FETs because you could not do a fresh transfer. And now there is genuine concern about macrosomic fetuses with frozen embryo transfers. So this, ladies and gentlemen, is the correct way to do dual stimulation. Your first stimulation should begin in the luteal phase. So you document ovulation, then begin FSH or HMG, add the antagonist, give an agonist trigger, do your retrieval, wait for menstruation. Then day 2, you give a conventional follicular phase stimulation. This time give the HCG trigger and do a fresh embryo transfer with a good luteal phase support. So of course, for the embryo transfer, you can use the embryos which are freshly generated in the follicular phase or those which you froze in the luteal phase stimulation, whichever were of better quality. So this is what the real dual stimulation would mean. But again, as of now, it is only recommended for patients of cancer who are undergoing chemotherapy and in a rush to freeze as many eggs as possible. Otherwise, we still don't have enough data to know whether the luteal phase generated embryos are better and more giving higher pregnancy rates than follicular phase stimulated embryos. What about freeze-all? We often hear that, oh, she has only 1 or 2 embryos, so let's do freeze-all. Again, no logic. If she has a good triple line endometrium, her progesterone on day of HCG is between 0.5 and 1.5, and she has given less than 10 oocytes, freeze all and fresh transfer will give you absolutely identical pregnancy rates. What about ICSI for all? Again, we hear that, oh, there's just 2 eggs. Let's not take a risk with IVF. Let's do ICSI. Please remember, there is no data to support this practice. In fact, most of the papers and evidence is in favor of doing IVF for IVF and ICSI for ICSI patients. And you, just because she is above the age of 35 or she has few oocytes, it does not mean you have to jump into ICSI. What really works well for Poseidon 4, and I recommend all of you do this, for all your women above the age of 35 who give just 2 or 3 oocytes, please do oocyte activation after ICSI has been performed. It's very simple to do. You get special ready-made media, calcium ionophore activation. You just have to inject your oocytes when ICSI is done and then incubate them for 15 minutes in these calcium ionophore droplets. Then wash it off and put it in your regular culture medium, and you will definitely see a 3-fold increase in the possibility of getting more than one top quality embryo, and definitely better quality embryos and blastocysts with higher pregnancy rates. So before I end, do we have evidence of endocrine disruptor chemicals, EDCs, on IVF outcomes and oocytes and embryos? And yes, we have publications from 2020 onwards clearly showing that oocyte quality is affected with exposure to pesticides, generalized oxidative stress. Oocyte dysmorphisms may reflect poor competence for development into a good embryo, and pesticide-linked defects in oocyte quality are likely to degrade the competence for the development of a genetically undamaged embryo. What about impact on embryo development? Again, pesticides have been shown to dysregulate embryonic genome activation, blastocyst formation declined with the concentration of organochlorines and atrazine, poor metabolic and genetic status during embryo development. And therefore, simple take-home points here that women who consume high levels of pesticide residues in fruits and vegetables or who live in an area with high pesticide exposure often have an above average risk of miscarriage, as this study showed. Another study showed that the probability of clinical pregnancy was 18% below the average, and the live birth rate was 26% below the average in women exposed to pesticides. And PCB and endosulfan have been linked to repeated implantation failures. What about epigenetics? And epigenetics, of course, we have limited knowledge, but what is the impact of these EDCs upon non-genetic inheritance patterns? And remember, we owe a huge responsibility to not only the next generation, but all the generations to come. Epigenetic means which genes are turned off and which genes are turned off in the genetic pool because of environmental or maternal influences. And remember that these could have long-term adverse consequences on the health of the offspring. Germ cells particularly are vulnerable to EDC exposure with resulting epigenetic changes, and you are also increasing the risk for the fetus to develop disease later in life. So, of course, again, we know, as this slide shows, that you are not only affecting the woman in question, but you're also probably affecting the children and the grandchildren when we consider environmental influences on egg and sperm quality. So what does the future hold for poor responders? Of course, we keep hearing talk of intra-ovarian PRP. I'm sure all of you have heard enough of that. The evidence as of now is not very, very great, and most ASHRAE, SRM, etc. still consider the procedure to be experimental, but we have a few papers here and there showing improvement in antral counts, mature oocytes, number of blastocysts, and maybe in the young age group. So I restrict intra-ovarian PRP only if the woman is under the age of 40 with an AMH of 0.3 or so, not 0.01 or something like that, and maybe an antral follicle count of 1 or 2 to give them a real good chance with intra-ovarian PRP. What seems to be exciting is OFA, that is ovarian fragmentation for follicular activation, which Kawamura first did in 2013, but he was doing double laparoscopy. So today he'll do a laparoscopy, take a ovarian tissue, cut it up into small pieces, then incubate it with P10 inhibitors to promote regeneration of primordial follicles and follicular growth. Then they found out after 48 hours, he would do a second laparoscopy to reimplant those small pieces. But then they found that P10 inhibitors are carcinogenic. So now the latest approach is to do it in one step. You do a laparoscopy, retrieve 1 or 2 centimeter ovarian cortical biopsy specimen, fragment it, small pieces, immediately at the same sitting, create some subcortical pockets, and fill up those pockets with the tissue fragments. So you don't need a double laparoscopy, you don't need P10 inhibitors. The logic is that you are interrupting the hippo pathway, and the hippo pathway is what regulates proliferation of cells in all human organs. Now here, of course, we want to remove that inhibition of regeneration because we want follicles to regenerate, and that is why by doing this kind of fragmentation and reimplantation, you would interrupt the hippo pathway. So recently I heard another interesting presentation where they do a combination. So they do OFA and at the same time also inject a subcortical PRP, 2 injections on both surfaces of both ovaries, and apparently you get a better response from these patients. So we are early days yet. Poseidon 1 and 2, to summarize, of course, pre-treatment most important. So either give estradiol or antagonist or use the agonist. Ensure your starting dose is correct. Identify patients with polymorphisms and add more LH for them from the beginning, and try to go back to using our gold standard agonist protocol. 3 and 4, overdosing doesn't help. Going to 600 and 900 doesn't help at all. Again, the agonist does better for a lot of them purely by giving more synchronous follicles. Dual stimulation in the correct manner and not the conventional manner. Ovarian activation, and of course, when all fails, oocyte donation. So this is just one slide of what I actually do in practice. 2 months of coenzyme Q, resveratrol, ARG9, leucine, glutathione, vitamin D, and folic acid. Testosterone gel just for 20 days pre-stimulation. First choice protocol, long agonist with HMG 450. If that fails, second choice protocol, short antagonist, again with mandatory pre-treatment to ensure synchrony. Dual stimulation I have discontinued and will only restart once I'm sure that the new way of doing it has any real benefits for the patient. We are going back to doing a lot of fresh embryo transfers because we want a corpus luteum in early pregnancy to reduce the risk of PIH and macrosomia. So I guess all of us need to now stop seeing this and do something about this, because we really can't have our next generation of females being born with a diminished ovarian reserve. Please, please, please don't take these signs very lightly. We need to be serious about it. We need to educate children and their children that all these things are not good for fertility. We need to see a lovely environment like this everywhere in the world. And I hope that all of us can create enough awareness, especially with this new society like ours, the one today we are having on environment. And with that, we come to the end. And thank you, everyone, ladies and gentlemen, and the organizers, of course, Sushma, Bindu, Rajvi, Payal, Nidhi, everybody who's been instrumental for putting together this wonderful and very unique webinar on such a difficult topic. Thank you so much.
Thank you, Jatin sir, for
Thank
this
you.
outstanding presentation
Amazing. As
and
usual,
sharing your
amazing.
expertise.
Yeah,
It was
really
incredibly
amazing.
valuable and engaging, sir.
Thank you. Thank you.
So moving
To
ahead,
do justice to this really difficult topic. I mean,
I
how
was so scared.
how
I
well
didn't know.
you
But you completed all the things, and really it was very informative and wonderful.
and
Very
what
nice.
a wonderful amalgamation of how environmental factors, poor ovarian reserve, and then how to proceed with the protocols. Excellent, sir.
Yeah,
Excellent.
only he can do.
Yes,
So I
sir.
have a question actually.
Yeah,
So
sure.
how do you practically counsel these girls who are coming with smoking history and vaping history?
No, so it's difficult, but you have to show them data. Like I keep on my lab, on my desktop, I keep it ready, So we show them data of the adverse effects of smoking. Though, of course, there are a lot of papers showing IUGR, miscarriages. Now we even scare the male partner. It's not only the female partner. So we tell the male partner also that because of your smoking, baby can develop autism, IUGR, miscarriages, abnormalities, trisomies, everything, So they need very aggressive approach. Of course, it's not easy. You and me both know. So we try to encourage them, okay, switch to maybe nicotine, this gum or chewing gum or patches, or there is some, there are a lot of new drugs which have come out. Of course, they need an expert to give it to them. Apparently, if you take that tablet once daily for 2 months, you can quit nicotine forever. So it's basically education, It should not be just recreational, If they're real addicts, they need de-addiction.
Yeah, so the de-addiction may take some time, right? So how much time do you give them? Like, okay, fine, you go ahead with the process of rehabilitation, de-addiction, and then come back. Maybe after 3 months or 6 months, how much time do you give? Like, is there something like that?
But generally now nobody is going to quit in a month or two, right? Even if they reduce it, then what else can you do? If you tell them come back after 6 months, she's not going to come back to you.
Yes, true.
So this is all advice we have to give to college girls, because we are talking of preventive medicine more. So
Yeah.
actually in practice with couples who walk in every day, you can tell them at the most.
I think, sir, with this quote, I would say that I think we, in colleges and schools, we should have this sessions on
Awareness program.
addictions,
Yeah.
actually, which are going on, like becoming rampant nowadays, actually.
And a lot of gymming. I mean, this fad about going to the gym, having corticosteroids and all kinds of things, the protein shakes and everything, it's going to harm their fertility.
Definitely,
Yeah.
definitely.
Excuse me, can we go ahead? Because we
Yes.
are having
Okay,
panel
so
also.
yeah. So moving ahead,
So thank you,
we all
everybody.
know that environmental
Thank you
factors
very
are
much.
slowly.
Thank you.
Yeah, thank you, sir.
Thank you.
As we all know that environmental factors are slowly eroding fertility. So let's move on to our panel discussion on these factors which affect fertility. Joining us are our experts who will offer us insights on this critical intersection of environment and infertility. I invite our moderators, Dr. Manjushri Boop. She's a well-known IVF specialist of Amravati. She's a past president Amravati OBGY Society. She has books, papers, and presentations to her credit. We welcome you, ma'am. Our second moderator is Dr. Anju Mathur. She's a senior consultant and director, Mangalam Hospital, Jaipur. She's HOD and reproductive medicine, NIMS, Jaipur. She's also past secretary of IFS Rajasthan chapter. Welcome, Anju ma'am. I hand over the mic to Payal for introducing all our panelists for today.
Thank you, ma'am. Today, the first panelist for our session is Dr. Pranita Chitnavis, madam. Madam is ex-past president of IMA Gondia and ex-past president of Gynec Society Gondia. She has been practicing gynecologist and IVF specialist since more than 2 decades. Next panelist for today's session is Dr. Shilpi Sood, ma'am. Ma'am is consultant and managing director of Diva Fertility Center, Nagpur and Safal Hospital. She has been past president of Nagpur Gynec Society, past secretary of IFS Vidarbha Chapter. She has been into many conferences. She has won many gold medalists, and she has been recently invited at Vigo, Paris to present clinical applications of pelvic anatomy. We welcome you, ma'am. Our next panelist today is Dr. Shalaka Mamidwar. Dr. Ma'am is consultant gynecologist at Manumai Test Tube Baby Center, Chandrapur. She has special interest in infertility. She has been vice president of IMA, COGS, member of infertility committee of FOXY, and she has published many papers and has been faculty at many conferences. We welcome you, ma'am. Next panelist today is Dr. Vinod S. Agrawal. Sir is clinical director at Spurs IVF and consultant laparoscopic surgeon and also consultant of Brahmanand Narayan Multi-Speciality Hospital, Jamshedpur. Sir has been president of Jamshedpur Gynec Society and also a founder member of ISAR. He has the credit of establishing first IVF center in Jamshedpur. We welcome you, sir. Our next panelist today is Dr. Indrayani Hatwar. Ma'am is chairman of Icon Hospital, Nagpur. She has held various posts in IMA, NOGS, and has been a past secretary of Nagpur Medicos JCs. We welcome you, ma'am. Next panelist today is Dr. Chirag Gupta. Sir is a uroenterologist and a microsurgeon having current affiliation, assistant professor at JNU Medical College, Jaipur. Sir is highly specialized, skilled in microsurgical varicocele surgeries, microtesse, microscopic VA, penile implants, and so on. He has been faculty in many conferences. He has been many publications in his credit, and he has published many books and chapters also. We welcome you, sir. Over to moderators now.
Hi, good evening, excellent evening to one and all. It's really, am I audible?
Yes, yes. Yes, ma'am, you are audible.
Yes. I'm audible. Okay, okay. Excellent evening to one and all. And after such excellent talks by our esteemed speakers, Dr. Jatin Shah sir, which every IVF consultant, not only of India, but abroad also, like they really adore him for his talks. And similarly, Dr. Rajvi Mehta, who has presented so well. The topic for this panel has already been spoken, but let's again have a nutshell of the all environmental factors which are responsible for increasing fertility. Can I share my screen, please?
Yes, ma'am, you can.
Is it?
Yes, ma'am. There?
Yes.
Just make it full screen.
Today's, yeah, it's full screen. Yeah, it's done.
Yeah.
I suppose.
Yes, yes.
Yes. Everything is clear and get set go for the panel.
Yes, please go ahead.
Yes, yes. So today's topic is environmental factors in infertility. And at the outset, I must thank my dearest friend, Sushma ma'am, for giving me this opportunity and making me read voraciously on this topic, and it was an eye opener. At the end of the day, I said it is a topic we need to carry forward, not for our infertile couple, for generations also, as everyone has spoken of, and also like why not to avoid infertility rather than treating infertility. So better is we should prevent infertility happening rather than treating infertility and opening multiple IVF centers. So like my co-moderator is Dr. Anju Mathur, who is a very close friend of me because we had worked together with Morpheus for pretty long time. So we'll go ahead. Yes, Anju ma'am, we can start. Are you there?
Yes,
Yes, yes.
doctor.
So we have esteemed panelists, Dr. Chirag Gupta, Dr. Indrayani Hatwa, Dr. Binod Agarwal, Dr. Shilpi Sood, Dr. Shalakha Mamidwar, and Dr. Pranita Chitnevis. So infertility is common condition with important psychological, emotional, demographic, and medical implication. It's a unique medical condition where not a single person but couple is involved. And demand for fertility services have grown substantially. Even prevalence of infertility has increased, but demand has really increased because हर इंसान चाहता है मैं जब चाहूं तभी बच्चा हो, which is not, and they really come to all of us like बस ये महीने में pregnancy होना चाहिए. We don't know what you do, but we want pregnancy this month, isn't it?
Yes.
So there are variety of factors which are affecting fertility. It could be physical, chemical, biological, behavioral, or socio-economic, and definitely your lifestyle. So there's different factors we are going to take during this journey or sailing through this ship. Like it could be air pollution, chemical, pesticide, illicit pharmaceuticals, smoking, drinking, disturbed circadian rhythm, obesity, improper eating habits, socioeconomic factors, even STIs and sexual violence, and radiation, which is on top of it. We must thank here the Wi-Fi, which is giving us this wonderful webinar, but at the same time, it is giving us some radiation. So coming to, we have designed it into case-based scenario. First case is young couple who is coming to my friend, Dr. Shalakha from Chandrapur. Female partner is 27-year-old. She is a housewife. Male is 29 years, working in coal mines. They're married since 5 years. They're trying to conceive since 4 years, coming for regular checkup to ma'am. And her baseline USG is normal, but semen analysis on baseline scan, baseline is only 3 million with severe Oates disease. So my question goes to ma'am only. What could be the cause of infertility? Not the cause of infertility, rather the question should have been framed as what could be the cause of such a bad semen parameter to a coal mine worker.
Yeah, hello. Yeah, can you hear me, ma'am?
Yes, you are
Yeah.
crystal clear.
Yeah. Okay. So it's very obvious that since the male partner is working in the coal mine, he has been exposed to many toxins. Hello.
Yes. Please carry on. Please carry on, ma'am. Hello. Is it a net issue?
Having some
internet problem?
Some net.
So
Dr. Indrani can answer till the time.
Yeah. Dr. Indrani can take up, or we have an andrologist, Dr. Chirag Gupta. Any one of you can take up the question?
Yes, ma'am. Actually,
mine worker, yeah.
In this case, definitely this patient is exposed to the air pollutants which are present in the coal mines, and that particulate matters which our esteemed speakers have discussed previously also, that they can lead to chromatin structure disruption and mitochondrial damage. Still, I will like to examine the patient because this history itself is not enough, and maybe he is having some correctable factors which we can treat and give them natural pregnancy.
So So, my question again, if the madam is there, because she's also a senior gynecologist practicing since many years, she's residing in a coal mine area. So, had she been seeing male factor infertility in on rise, especially in coal mine workers? Her, if her net is stable, she can answer this. Okay, we can take up. We can go ahead with that. Once she comes in, she may add her inputs, because over the years, we are seeing that male factor is becoming more and more prevalent in cases of infertility treatment. So, different agricultural emission, transport, industrial emission, this all contains very toxic gases like carbon monoxide, nitrous oxide, sulfur dioxide, ozone, and lead. These are all chemicals which are present in air, and this air pollution, it could be either not only from the mine, we all are exposed to it through motor vehicle exhaust, factories, fire, household, even the agricultural waste treatment, oil refineries, natural resources, volcanic eruptions, or wind. So it is not only the coal mine worker, everyone which is being surrounded by air, and with a polluted air, we all are at risk. And this air pollution has different ways, like it causes hormonal disruption by reactive oxygen, causing reactive oxygen species. It also sperm DNA alteration. And as Jatin sir has told, that it also causes epigenetic changes. So major factor that may contribute for infertility is, of course, along with air pollution, it is exposure to heat, because mine workers, they are exposed to heat, and temperature plays a crucial role in maintaining normal spermatogenesis. That's why testes are put in scrotum and not inside the body, where temperature is 2 to 4 degrees less. So definitely high temperature in scrotum is another cause of decreased sperm count, motility, morphology, everything, and with increased DNA fragmentation. So this all depicts it. So definitely, as Dr. Chirag has rightly pointed, that he need to examine a patient and then come to a conclusion whether it is only an environmental which is causing a problem, or whether it could be secondary to some inherent disease in him which is responsible for impaired or severe Oates disease. So here I would like to hand over mic to my friend, co-moderator, Dr. Anju Mathur, who is also doing some studies on this decreasing sperm parameters. Madam, please, can you take up? Here we are
Thank
not
you.
going to, Madam,
Thank you,
here
Dr.
we are not going to take the treatment point only. We are going to restrict ourselves to
Yes.
environmental toxins. So treatment part will not be a part of this panel.
Thank you, Dr. Manju. I recommend, it was really excellent lecture by Dr. Jatin as usual. And as you said, recently for last 1 year or so, we have been using computerized semen analysis, and I have done a small study in which we have seen the patients who are taking these पुड़िया, ये गुटखा जिसको हम लोग बोलते हैं, patients who are taking gutka in any or tobacco in any form, the number of the sperm is not affected, but the motility is severely affected. And once this tobacco intake is reduced for more than 12 weeks, then the motility starts coming up slowly. But it is a major this thing, though I have not, I don't have the number, is not much. But it is a, remarkable thing to see that the direct effect of tobacco on the motility of the sperms. So now we come to the second case. This is a young, high-profile couple, and female is 30 and the male is 31 years. They are married for 5 years and they are trying to conceive right from the beginning. Both are IT professionals and with US company, that is late night calls and meetings. And both of them have BMI in the higher range. That is, her BMI is 32 and even the male has a higher BMI. AMH of the female is 0.6 and the semen analysis is 2 million per ml. So in this case, what would be the cause of infertility? Dr. Shilpi can take this. Dr. Shilpi?
Yes, ma'am. Dr. Anju, thank you so much for this question. I believe this is a very important aspect these days we are seeing in our regular OPD. These couple IT professionals, they have a sedentary lifestyle, and both of them having a high BMI, and their definitely their circadian rhythm is affected. That is affecting the hormonal balance in both of them, and they are having a late night, you can say, work from home profile, and then they also being affected carrying a laptop all the time, working with the laptop. Although few of the studies are really giving like the waves generated through these gadgets, they're affecting the sperm quality, and as I said, like the ovarian reserve is coming down in the female partner also. So this is a load of like lack of sleep, and as being mentioned, like, and other stress related condition in these couple have given a low the ovarian reserve and the uh, low
Yes.
sperm count also.
See, the important thing is this type of couple is this kind of scene is seen in almost 30% or maybe 40% of the couple in the you can say the bigger cities. So this couple suddenly they want to have a family, and without working on it, we see that this is very common thing, that the sedentary lifestyle and late sleep, not getting up with the sun, and then using cooked food which comes in plastics, drinking and smoking. All this is very detrimental to the reproduction in whatever way, as Dr. Jatin has pointed out. It really works on so many factors. It is very difficult to point out and to say that obesity doesn't cause this, or obesity is causing it. But the main thing is that lack of sleep, stress in so many ways, and the smoking and drinking, all this is coming hand in hand. And when these things are together, there is stress, and it is working endocrine level, and this pituitary axis suppression, and which results into reduced level of thyroid hormones, which are essential for regulating the metabolic phenomena of both male and female partner and the overall health. The chronic stress is related to repetitive disruption of hypothalamic axis, which again leads to anabolic and catabolic state of the mind. Consequences are this suppression can contribute to various health issues, and including weight gain, fatigue, mood disorders, further impacting reproductive functions. So this is the main thing. The functioning has to start right from the beginning, and when the couple wants to conceive, the first thing to see is that the BMI should be ideal BMI, as we all know, is 23, 24, and here the BMI is more than 30. More than 30 BMI needs to be, the weight loss is required, and rest of the factors are required. But then this cannot be done because you are wanting a baby. So it is to be started right from the youth, from the college levels, as we were just discussing. Alcohol consumption and reproductive health, that has just said that it doesn't affect directly, but there are incidences in which we see that it is affecting the other phenomena, not just directly affecting the reproduction. Smoking and reproductive health. Smoking leads to disruption in ovulatory disorders, and there are pregnancy complications, as we have seen. So all these things are leading to low fertility and low, full-term pregnancies. Packaged food, these Zomatos and Swiggies are causing this ultra processed foods. These foods are often high in unhealthy fats, sugars, and additives in the form of preservatives and colors, which are low in essential nutrients like vitamins, minerals, and antioxidants. They may also interfere with the endocrine system, leading to hormonal imbalances. Studies have linked UPF consumption to poorer semen quality, including reduced sperm count, concentration, and motility. So, then the next thing, which is we have already discussed, use of plastics. Plastics are avoidable also and not avoidable also, but plastic use has become indispensable in our daily lives. But being non-biodegradable, it has now become a major cause of concern for all over the world. Bisphenol A, a major component of plastic, is released into the environment during the process of production, use, or disposal of plastics, and from breakdown of industrial plastic waste. So these things have even in a study, it was also seen in the placenta, the microfibers of plastics are seen. So plastic use has become indispensable, and these bisphenol A is a major component of plastic, is released into the environment, as we have already seen. Next slide. Now we case number 3, Dr.
Yeah, I'll take over.
The next case.
So, like my all dear panelists, do you think that this all urbanization is only leading to infertility? Can anyone take up? Whether infertility is only urban disorder or it is a only lifestyle which is seen in urban India or urban world is only causing infertility? Anyone can take up?
So most of the
Dr. Indraini? Yeah.
So most of the agricultural supplements which they are using in rural areas are actually endocrine disruptors, which are leading to low sperm counts in males.
Yes.
Those are also very important.
I want to add, madam, to it.
Yes, please, madam. Chitnis, madam, please. Would like to hear
Since
from you.
long we are seeing that previously it was more of a male infertility in rural areas also, in towns and villages. But the lifestyle of towns and villages is now changed, and they are living just like an urban life. The education, they are getting jobs up to 35 to 38 years, and their food habits has also changed. So the female infertility is also increased in the towns and villages.
Such
So
an
I don't.
excellent answer, madam. Such an excellent answer. That was what we really wanted to put up, that it is not only urbanization. Don't blame only lifestyle. Similar increase of infertility is seen in rural India. And let's see, it's common in rural India. Let's come to this case. And you are only going to take up, Pranita, madam. For this case, young couple coming from rural India, female is 26-year-old, housewife, male is 28-year farmer. They are married since 4 years, trying to conceive since 3 years. Her AFC is also 6 with AMH of 1 and semen analysis is showing 8 million with Oates disorder. So like, what would you like to say that what could be the cause? Treatment, as I told, we are not going to discuss here, but what are the causes so that we can prevent it?
Madam, we have seen in these young patients also the low AMH, and I don't think that we should bother much about the low AMH in one reading only. We should see their nutrition. Most of these patients are having hypoproteinemia, which is more common in villages. They are deficient in vitamins also.
Yes.
And the activity they are doing exertions and not exercises. So the vascular supply of ovary is insufficient. So if we do their protein supplementation, their regular workup, and we can do some investigations which are treatable in them, and we can repeat the AMH after some time and see for ovulation study and other factors. So we can do a medical management in these females. 8 million count in male, if the motility is good and all other factors are normal, I think we can wait for this patient to conceive if she is a ovulatory patient and all other factors are normal.
Okay, excellent answer, madam. So the first and foremost is nutritional status of a rural India people. If we want to work on nutritional status as a first strategy when they come to you, giving a good protein supplement, asking them to have lifestyle modification, but in different direction, in a healthy way. Like urban people, you have to tell them in a different way rather than rural India people. And it is cheap. Like lifestyle modification is a very cheap option. Everything is available in amount of the cash which is payable for rural India people also. So it is not that they can't afford matki chi usar, they can't afford all this carrots, tomatoes, which is easily
Madam, even
available and
egg,
there.
even egg is a good protein because many, almost 80 to 85% of these people are egg eaters. They may not have a fish or chicken, but they can eat egg.
Yeah,
This is
that's
my experience of last so many years.
yeah.
So that is a very cheap option to give them a good quality protein.
That's true. And I would like to just add on my personal study. Like we all use egg donors, and I used to give 1 kg dal to them. They are all vegetarian. So 1 kg tuar dal to them and ask them to eat yourself daily. And we used to get a very good result, and they used to be happy with that also.
Yes,
So like
definitely,
egg
definitely.
or pulses, this all can be added, and that's just a practical tip. But definitely environmental toxins are causing infertility in rural India. So, Dr. Hatwar, can you comment on what are the different environmental toxin which can cause infertility, both to male and female? Dr. Indraini, please. Dr. Indraini is there. Dr. Mamitwar?
Yes, ma'am. Can you hear me now?
Yeah. You are,
Yeah.
we can hear you.
Okay. Now I'm back. Ma'am, many organochlorine compounds like chlorinated pesticides, then there are biphenyls, there are bisphenol, BPA, which is commonly used, then other organophosphate pesticides and a lot of herbicides, which can disrupt the female partner as well as the male partner, causing a lot of issues in infertility.
Yes, excellent. These are all the things. This environmental toxin, they causes basically infertility in 4 ways. It causes endocrinal disruption. It damages female reproductive system. It damages male reproductive system. And it impaired fetal viability. And as Jatin sir has so rightly and so nicely narrated that it is not this generation. We have to think of next generation and other next generation. Great grandchildren of ours should have a great fertility, and it is because it causes a various epigenetic changes which goes in generations. So we are indebted to treat this environmental factor and prevent this in our lifestyle. So can anyone take up what are different endocrine disrupting chemicals? Name you have suggested, but we would like to know the pathology, how they are working on it, so that we, at the end of the talk or panel, we should be very clear that this chemical is causing these are changes. So can anyone take it? Dr. Indraini is there? Dr. Shilpi is there? Dr. Chirag Gupta, would you like to, or Dr. Pranita, Dr. Shilpi, whosoever are available can take up the answer? Or me and Anju ma'am are there to carry forward the
Ma'am,
things.
basically it disrupts the hypothalamic and pituitary functions. Secretion of GnRH, LH, and FSH is directly hampered.
Excellent, ma'am. So EDC mechanism of action we really need to know. They have hormone receptor binding, and this bind to androgen or estrogen receptors, triggering agonist or antagonist action, leading to increase or decrease gene expression of sex-specific genes. Secondly, hormone metabolism interference. So EDC can affect P450 genes in the liver, which metabolizes steroid hormone and further disrupting the hormonal imbalance. At the same time, the steroidogenic enzyme inhibition it causes, it can inhibit the activity of 5-alpha reductase enzyme responsible for dihydrotestosterone production, which is very important for all our oocytes to be there, and it causes affecting masculinization of external genitalia and prostate. It do have epigenetic and mRNA changes, which is seen in mice and which is carried forward for generations there. So definitely this all EDC, they are very detrimental to all of us. And as madam has said that it could be hexachlorocyclonexone, it could be PCBs, that is polychlorinated biphenyls. It could be DDT, which we all have used since our childhood for Mungi Aliki DDT Taka. That was used to be there, and we used to have a cans and cans of DDT at home. So dichloro, diphenyl, trichloroethane is the name for it. And along with that, these all are present not only as a pesticide. These are there in perfumes, plastic container, cleaning product, pesticide, deodorant, and smoking. So definitely dioxy, we'll just say the name, then pesticide and herbicides. Next is DDT, which is already phthalic acid. And we have seen the mechanism of action of all this, how it disrupts the fertility and how it causes infertility. So now I hand over another case to my co-moderator, dear friend Anju. Ma'am, please.
So this is another case, and this is a young couple of 33 and 34 years respectively, married for 6 years, trying to conceive for 5 years. Apparently, most of the investigations are showing apparently normal, but now the AMH has come down to 0.4 for the female. Her BMI is 32, and the male partner's BMI is 36 with semen analysis 5 million now. This is initially their parameters were normal. So, Dr. Shilpi, can you tell me what do you think is the cause of infertility in this couple who's trying right from the beginning? You know, from 20s they were trying, 29, 30 they started trying.
I think Shilpi has gone for some emergency. She's not there.
Dr.
We have
Indrani,
Pranita, we have Shalaka ma'am, and we have Chirag
Shalaka,
Gupta.
ma'am, then Dr. Shalaka.
Ma'am, this seems like a lifestyle disorder, basically, which is affecting both the partners, and considering their high BMIs, and as was discussed earlier, a lot of use of mobiles and laptops, and these things must be contributing in their fertility profile.
Okay. So you feel that obesity was the cause, right?
Yes, one of the most
Anybody else?
important cause. Yeah.
Any other panelist of any other opinion for this couple? Dr. Chirag?
For males, I will like to add, madam, if patient is having obesity, then the chances of having a reversal of T ratio is higher. So that can lead to suppression of the HPG excess, leading to decrease in the sperm count.
So, can you elaborate, Dr. Chirag, how does increased BMI in a male affects the sperm? Sperm
Males,
quality or the sperm number, how does it affect?
in obese patients, most testosterone is converted into estradiol, leading to reversal of the TE ratio, leading to suppression of the HPG excess by estradiol. And so intratesticular testosterone is less. Another way is just increase in the free radicals, leading to low sperm count, leading to oxidative stress, which leads to sperm fragmentation and poor sperm count and motility.
Okay, thank you, Dr. Chirag. So we have seen that obese women have 3 times more risk of infertility than non-obese women in the same age group and same AMH. While in males, as Dr. Chirag has just pointed out, besides the hormonal problems, which is because of obesity, increased adipose tissue, there are physical problems also like snoring and sleep apnea, and so that all causes EDs, ejaculatory dysfunctions also in obesity. So obesity can cause infertility in a number of mechanisms. It is not just a one way. There may be hormonal changes which is caused by obesity that impact fertility, as decreasing the testosterone, FSH, and inhibin B in men, and increase androgen metabolism and elevated estrogen levels in women. And adipose tissue is more in obese females and males. This produces factors like leptin and FFA and cytokines that can affect ovarian and endometrial function. Leptin levels are high in people with obesity, and leptin in the ovaries can interfere with ovulation. Insulin resistance, as all of us know, is common in people with obesity and can impact the frequency and amplitude of LH and secretion pulses, which may contribute to infertility. So, besides obesity, do you think there was any other factor in this couple? Dr. Indrani, are you there,
She's
Dr.
not joined. She's not joined.
Acha, and Dr. Pranita, she's also
And
gone?
she may be having an ovulation. Her AMH levels are very low,
Very low.
and we have to see for her ovulation whether she is ovulating regularly or not ovulating. So ovulatory may be one of the cause, which is again common in obesity, age, and low AMH.
Yes, very nice, doctor. The hormonal imbalances in obesity, actually, how does it affect infertility? The sex hormone binding globulin is less. Insulin like growth hormones are also decreased, growth hormones are decreased, and leptin and estrogen are increased. So, all these lead to an ovulation. So, further on, as we see, the next slide, Dr. Manju. Next slide, Dr. Manju. So infertility, as because there is a lot of fat affecting this thing. There is in obesity, the insulin resistance and reproductive functions are affected, and the environmental, genetic, and lifestyle factors, they lead to obesity, leading to increase in adipose tissue. Can I have the next slide, Manju? Manju, can I have the next slide? Increased adipose tissue then leads to altered epidonectin and resistant leptin and ghrelin, which this all increases alters the lipid metabolism. I'm sorry, I'm not able to show the slide. There is change in the levels of steroid hormones. All this affects the ovulation. In males, all these factors, they increase the FSH and LH, and hence causes spermatogenesis failure also. Can we have the presentation, Manju? Dr. Manju?
Manjushri madam, you are mute.
So the possible neuroendocrine pathways is hypothalamic pituitary gonadal axis, insulin signaling pathways, adipokine hormones, polysaturated fats, that is PUFA, and mTOR complex. So these are the things affecting the obesity and hence leading to fertility failures. Now the next question comes is, can we reverse infertility in these patients who are obese? So in this, we have to start, actually educating our youngsters right from their adolescence to be mindful of their diet, eating a healthy diet rich in fruits, vegetables, and whole grain, and like these things, the millets have come. These can help in reduce your risk of obesity, which is a risk factor for infertility. To exercise regularly, to use the body is the most important thing. And to use the body means if we are not actually using in our work, we should exercise regularly, which can help to maintain weight and an exact BMI, to reduce the health problems, and to reduce your exposure to toxins and pollutants. Be mindful of your exposure to toxins and pollutants like lead, mercury, pesticides, DDT, etc. Use natural cleaning products and avoid using pesticides in your home and garden. This is extremely important. And quit smoking and alcohol as much, decrease alcohol as much as possible. Smoking has been linked to decreased fertility, as we have seen since the evening. And in both men and women, if you smoke, quitting can improve your chances of conceiving. So, recommendation for action. Recommendation for actions should be there should be education and awareness right from the school and college days to preserve fertility, to educate patients, not just for when you're married, then you start working on it. But this should be 1 point program right from the childhood. The education and the awareness, raising the awareness about the impact of lifestyle, environment, and socio-economic factors on fertility is crucial for our generation, for empowering individuals make informed choices. The policy changes are required. The policymakers should prioritize measures to reduce exposure to environmental toxins, promote health, and ensure equitable access to healthcare. Then research and innovation is needed, like such workshops and webinars. The continued research is needed to understand the complex mechanism by which these factors which affect fertility, and to develop effective interventions and treatments. So with this we come to the end. I'm sorry for this last 2 slides which we could not show you because I cannot contact with Dr. Manju.
I think I got logged out in between, and that
Yeah.
was a reason. I think I don't know why the connecting issue must be there. Am I audible right now?
Yes, you
Yes,
are audible.
yes, yes.
Okay, in between, I think there was a connection issue because it's raining outside, and that was a reason we could not. But definitely, you have taken it so well, that reverse infertility, and I would just like to.
You can just move on with the slides and go on to recommendation for action.
Yeah.
Reversal
Actually,
I've
I'm
already done.
trying, but you have taken up nicely that thing. I hope I can go. No, it has hanged, madam. So you have nicely taken up that it is the thing, it is reversing infertility. We really need to reverse all environmental factor. But with the modern lifestyle, and we cannot go back to the era, apes and apples era. But how mindful we can be in our diet, exercise, reduce exposure, quit smoking, have a lifestyle modification. Apart from that, at individual level, we really need to work at. Everyone was telling that policy maker, we need to involve policy maker. We need to tell them. All policy makers from our field need to talk to policy maker of government so that we can have some rationalized use of pesticide and all environmental toxin which are going in the body. So I think last slide, thank you. We have to personally only say to everyone because laptop has got hang. So thank you
Madam,
everyone.
am I audible to everyone now?
Oh my
Am I
God,
Yes,
audible?
Indrani.
my
Yeah,
whatever
now
you in
Because
was
what
done.
happened, I don't know. I was there, but I was not able to visualize what is happening. I think some
Oh,
connectivity problem. I tried to
exactly.
talk, but it wasn't showing me. I don't know. It was
We
some
kept
problem,
asking,
a
Dr.
technical
Priya,
problem, I think.
we had
Asking
called
for
it
Uh,
many time, Indrani, please call.
yes.
Please comment, please comment. But
Yes, I
anyway,
just want
next
to
panel.
comment one thing that
Yeah, please,
there's
go ahead.
lots of use of electromagnetic
Radiation.
EMF, what we say, radiation,
Yes,
and the TV screens, mobile screens. These youngsters are too much after all these things,
yes,
and they affect at your brain level, the pineal gland, and they're affecting at hypothalamus. They are disrupting that pulsatile release of LHRH, and the thing starts from all disruption of that hypothalamo pituitary ovarian axis, and that leads to this hormonal disruptions, and at the same time it is acting at the cellular levels, at the DNA level, and there they are causing fragmentation, protein lysis, and all those things. So it is very complex phenomenon, but I think it is like need of an hour that one should discuss all these things also, because we know theoretically there are so many causes of infertility, but these are like modern causes of infertility which are adding on our list of infertility problems. So I think that should also be, means we need for the research also on this topic.
yes, excellent answer, Indrani. We were waiting
That
for your
how
answers.
much electromagnetic radiation. Yeah.
Yeah, yeah.
I see that
I
as
can
you can
see
see me, and
Manish
yeah.
raised hand.
But really, it was a really wonderful webinar.
I'm
You
seeing
worked very
Manish
hard,
as
and
raising.
really you took great pains for this webinar. And everyone, it was really wonderful. Amazing.
Thank you, my
Actually, it was-
panelists. Thank you so much. Sorry for this,
Thank you, madam.
Wi-Fi
Thank you.
problems. Thank you, Dr. Sushma.
Anju Manju rocked.
Thank you.
Anju
Thank you,
Manju rocked.
madam. Oh,
Yes.
thank you so much, madam, and happy Friendship Week to every one of you.
Yes.
We all are great friends together.
Yes,
Yeah.
yes.
And
Thank
I
you so
can see Manish has raised hand. He wants to ask something or add something. Manish, are you there? Dr. Manish Baheti?
I think he left because I got that message that Manish left. I think he has left.
Okay,
I
okay,
think he's
okay.
unmute. He needs to be
I think, yeah.
unmuted because
I'm here. I'm here.
Yeah, yeah. So you can add on.
Yes, he is here.
He won't ask, he will add on. Manish, you can
मुझे
add.
पुष्पा मैडम ने स्टार्ट से एंड तक के अटका दिया है.
Ah, good, good. Good, good. The post demands your presence, precious presence. It was really at the end, we would like to thank Sushma ma'am, Bindu ma'am, and whole team of IFS for giving us this opportunity to read and present before you this infertility, environmental factors and infertility. Really a topic which needs research. And this
Really
is
requires.
for another generation we want to do it. It's not for us. Maybe our generation coming next and next, we need to really give a better world to them. Thank you so much, and we are grateful. Thank you.
They just wait for
Thank
vote
you.
of thanks.
Yeah, surely I'm there.
Yes,
But
Manish.
no worries, we are here.
Joint Secretary Vidarbha Chapter, I, Dr. Manish Baheti, would like to thank our President, Professor Dr. Pankaj Talwar, President IFS Central Body, and Dr. Shweta Mittal, Secretary General, Central IFS team, as well as our convener for this webinar, Dr. Sushma Deshmukh, and I would like to thank our main two speakers, Dr. Jatin Shah and Dr. Raju Mehta, who delivered a summarizing talk on this different topic, which really opened up my mind also. And I would like to thank the chairperson, Dr. Saranjit Singh, then panel moderator, Dr. Manjushri Goop Madam and Dr. Anju Mohta Madam, Mathur Madam, and our panelists, Dr. Pranita Chitnavis, Dr. Shilpi Sood, Dr. Shalaka Mabidwar, Dr. Indrani Hatwar, and Dr. Chirag Gupta. I really can say that due to those two mesmerizing talks and this wonderful panel, I lost my words on vote of thanks. It was a wonderful, wonderful session. I thank Dr. Bindu Chimote Madam, who is behind this all, Dr. Chimote Madam and Dr. Sushma Deshmukh. These two are pillars of Indian Fertility Society Vidarbha Chapter. And I would like to thank our MOCs, Dr. Payal Agrawal and Dr. Nidhi Gandhi, who conducted this webinar wonderfully. Thank you, everybody. I would like to say, even if I have not mentioned some names, I would be sorry for that, but I am thankful to everyone who have attended, the participants, the organizers, everyone. I will be thankful from my heart. Thank you.
Can you just all open the windows? We'll have photograph. Himanshu, can we have one photograph?
Sure, ma'am.
Please open your windows.
Done, ma'am.
Done?
Okay, thank you.
Thank you all. This was a
Thank
really
you.
wonderful
Thank
webinar.
you.
Eye-opener webinar, I will say rather.
You